12-year-old male is imaged following a minor ankle sprain. I am showing you ankle radiographs from two different patients. Please describe the findings.
The first radiograph demonstrates an eccentric, cortically based, lobulated lytic lesion in the distal tibial metadiaphysis, showing a well-defined, scalloped sclerotic border. The second radiograph shows a similar distal tibial lesion that is undergoing progressive internal sclerosis.
What is your primary diagnosis?
The findings are diagnostic of a benign fibroxanthoma of bone, which includes fibrous cortical defects and non-ossifying fibromas.
How do you distinguish a fibrous cortical defect from a non-ossifying fibroma?
They are histologically identical. The distinction is based purely on size, where lesions under 3 centimeters are termed fibrous cortical defects, and those 3 centimeters or larger are termed non-ossifying fibromas.
What is the typical natural history of these lesions as the patient skeleton matures?
They are benign, self-limiting lesions that typically regress spontaneously. As the patient reaches skeletal maturity, they heal through progressive osteosclerosis, starting from the diaphyseal side and often disappear completely by the mid-20s.
Under what radiographic circumstances does a non-ossifying fibroma become symptomatic or require surgical intervention?
They are typically asymptomatic incidental findings. Intervention or curettage is only considered if the lesion is large, involving more than 50% of the transverse bone diameter, which places the patient at high risk for a pathologic fracture.
What is the typical appearance of a non-ossifying fibroma on magnetic resonance imaging? And when would you see surrounding bone marrow edema?
On magnetic resonance imaging, it shows a well-defined low-signal sclerotic rim and heterogeneous central T1 and T2 signal reflecting fibrous tissue and lipid-laden histiocytes. Surrounding marrow edema is absent unless there is a pathologic microfracture.
Which genetic or clinical syndrome should you consider if multiple non-ossifying fibromas are present along with café-o-late spots?
Multiple lesions can be associated with neurofibromatosis type 1. They are also part of Jaffe-Campanacci syndrome, which includes multiple non-ossifying fibromas, café-o-late spots, mental retardation, and cardiovascular anomalies.
Finally, what are your clinical management recommendations for the incidental tibial lesion in this patient?
No treatment or biopsy is necessary. I recommend simple reassurance to the patient and parents, as this is a benign, self-limiting lesion that will heal spontaneously.